Thank you, Chairman, for your very kind introduction. I'm sorry to disappoint you folk. I'm not as pretty as Kate Caston, but I will try and take you through with the changes that we are experiencing with regard to commissioning of specialized services. Why have we got the NHS Commissioning Board? And the public stated aims of the NHS Commissioning Board is to uphold the NHS Constitution, make people better, improve the quality of services, and people might say, well, after Staffordshire, we're better. And then it is making sure that the patients that come along, they're treated fairly and equitably. And equally important for the NHS Commissioning Board, which will be responsible for something like £111 billion of public money, will be allocating these resources for best possible outcomes for patients now and for the future generation. What is the role for the NHS Commissioning Board? Let me kick off. It's been stated and restated that the National Commissioning Board will be patient-focused and a clinically led organization which will allocate resources to CCGs, clinical commissioning groups, that will be up and running from the 1st of April and will be responsible for something like 60 to 65% of the £112 billion of public funds. It will support clinical commissioning groups in their development and for commissioning evidence-based services for their patients. The NHS Commissioning Board will also be directly commissioning services. They'll be commissioning primary care, commissioning secondary care for military personnel and their families, for offender health, people in detention, public health programs, like some of the screening programs, and last but not least, will be for specialized services. And for specialized services, we are talking of something like £12 billion of funds that will be allocated by the NHS Commissioning Board. You will ask as to how is the NHS Commissioning Board going to deliver the commissioning of specialized services. Now, there are various directorates, but the biggest one in the NHS Commissioning Board is the Operations Directorate. And the Operations Directorate there'll be a national support team based in Leeds with presence in London. But the important folk that you will be interacting with will be the 27 area teams, and particularly 10 of them that will be commissioning specialized services. The local area teams, will be responsible for monitoring, supporting clinical commissioning groups, but also commissioning directly the directly commissioned services on behalf of the NHS Commissioning Board. And that includes specialized services. We don't talk about areas, we talk about regions, and there are going to be 4 regions: the North, Midland, East, London, and South. So you're sitting here in Sussex, but the South region extends right up to Milton Keynes, Cornwall to East Kent. And the 4 regions, their main tasks are to make sure that they provide clinical and professional leadership, so they'll be interacting with the Senates, and also to make sure that if you're going to have one national way of working, that what comes from the national support team is passed on to the area teams, and where need be, the area teams are supported by the region because the area teams may be small, and for some of the highly specialized services, it may have to be on a larger regional base. For clinicians and people delivering specialized services, the 10 area teams are as listed, and these area teams will host specialized commissioners, and they will be interacting with clinicians and the provider units and other stakeholders in making sure for the delivery of specialized services. You'll note that London has one area team. Previously, it was envisioned they may have 3, but it's 1. You are now sitting in Sussex, and the area team that will be covering Kent, Surrey, and Sussex will be based with the area team in Surrey and Sussex. And the rest of the 8 area teams will be commissioning for the rest of the country. At the start of the transition, we had more than 11 separate commissioning arrangements. There was arrangements for the national commissioning, which sat with the London Strategic Health Authority, and the 10 specialized commissioning groups across the country. It was commented that there's variable levels of commissioning and there wasn't consistency. Yes, there was national oversight, but the funds were allocated to Primary Care Trust, and the decisions were made locally, and they tended to be different. There was differential access, so people in Newcastle could have criteria for accessing services which were different to those in Brighton. Standards varied, and it was also commented that there wasn't a national strategy that could be clearly articulated. End of transition. We've been through transition now going on to about 2 years. And one may say, well, what of it? We're now arriving at having one national commissioning structure and one process, and that is across the specialized services. There will be national decisions in which some of you are involved with the clinical reference groups or the development of policies, and the implementation will be done locally. Regional structures, as I mentioned, to enable convergence of specifications and policies. And lastly, in 2006, there was the Carter Review and recommendations that flowed of having a very coherent national structure for commissioning specialized services, like yours. Planning convergence. Specifications have been developed for 139 specialized services, and about 39 clinical commissioning policies have also been consulted on and will be implemented. There has been comments in the papers as well as from patient groups that the consultation was too short. And part of the reason it happened was the fact that it could only have consultation after the Act had passed. There will be ongoing developments and consultation, both with the commissioning policies and for the service specifications. And just to reassure colleagues that the specifications and policies that you have come across, they're not set in stone. And there will be influence, there will be changes, and there'll be opportunity for people to shape things. At the moment, there is mapping that's being undertaken by commissioners across the country to see how the specifications and policies will impact. And also, I think in terms of the budgets, because some services need more development than others. Challenges. Yes, the NHS Commissioning Board is going to be faced with challenges. It already is. And the first one, in the times that we're living in, is that it has a statutory duty to financially break even. So 112 billion pounds allocated, it has no opportunity to overspend. It has a duty to safeguard and promote quality, promote research, development, and innovation, and that is within cash-limited budgets. And lastly is that there's one national solution. So the specifications will be national and policies will be national. So what happens in Manchester or Alder Hey, will be similar to what happens in Brighton. And that is going to be a challenge. So, Chairman, I think the message that I'm trying to convey, and Kate Caston would have conveyed, was that, be it at national, regional, or local level, that is one team. And that with the specialist and expert clinicians, we ought to have one conversation that drives the commissioning specifications as well as the policy and must have a clear focus. Yes, there'll be similar access and similar services for patients, but it might take some time to do that. So I think in wrapping up, Chairman, we've got to work together as one team. Patients, expert clinicians, the NHS Commissioning Board, and try and improve the services so they are one of the best as far as specialized services are concerned. Thank you.